Yeah. She nodded tentatively. Hi, everybody. This is, as you may have guessed, and I hope you're in the right place that you intended, the Generalist CCFP 105 Topics podcast.
Yes, it is. It's also meant to entertain and delight, Caleb.
We are delighted to have you back on the podcast, Eleanor. Are you done?
Yeah. I signed up for more. I'm doing a +1 in anesthesia in Calgary right now.
Oh, I love it. You're just looking for the lifestyle, eh?
Absolutely. Everyone loves staying up all night. Our favorite.
Well, good for you, though. Congratulations.
Thank you.
Like you're amongst the wonderful jewels of generalist contributors and team members who went on to do +1 or match to basically anything they wanted. So if you want to match to anything you want, come and help us out.
Yeah.
And she's back for more, because once you're in the generalist fam, you're forever in the generalist fam. Should we get going?
Sounds good.
Do you want to tell us who wrote this?
Yeah, so this was written by Thompson Don't. He put together an excellent overview of the testable objectives for the topic of obesity.
And then Eleanor came along and spruced up the place, put on some polish, added some wonderful, tasteful elements to it, and made it into the beautiful episode that you guys are going to hear.
Yeah, human factors.
So thanks for doing the hard part, Thompson. It's a tough topic because weight is intertwined with obviously concepts of self-worth, body image, moral character even, and there's been a push appropriately to decouple weight and health. So having obesity classified as a specific disease state and not just a single metric.
Obesity Canada published a guideline in 2020 that we will be referring to a lot in this episode, and it defines obesity as a chronic, progressive, and relapsing disease characterized by the presence of adiposity that impairs health and social well-being.
Yeah, what are we going to learn about today?
You'll learn some practical things for real-life visits that take into account real-life pressures of diet culture, how we as physicians can provide evidence-based advice that doesn't isolate or judge patients, and then you'll also learn what you need to know for the exam. And because we know language matters, you'll hear us use terms like large bodies instead of saying, someone is fat or like morbidly overweight. But today we'll stick with the medical jargon and avoid terms that stigmatize people.
So good. We're here for the good stuff. Let's get going. Objective 1. In patients who appear to be obese, make the diagnosis of obesity using a clear definition and inform them of that diagnosis.
Now, I have a bone to pick with BMI as an accurate tool to assess health, but the CCFP is pretty adamant that this is their gold standard.
This definition does actually deviate from the most recent obesity guidelines. So remember the episode that we had with the experts from the review course? They'll never ding you for being too accurate and too up to date. So if the guidelines say something else, go with the new guidelines.
Yeah, the CCFP needs to update themselves on this one. For the exam, you'll need to know what a quote-unquote normal BMI is and the cutoff for elevation, which is how they define a diagnosis of obesity.
If we run with the WHO, they say BMI exceeding 30 kilograms per meter squared and is subclassified into class 1, which is 30 to 34.9, class 2, which is 35 to 39.9, and class 3, which is anything 40 and above. There's also variation in the risks associated with these values in different populations. So in folks from Asia and South Asian populations, similar risk levels are met at lower BMIs. In people of African descent, the similar risk levels are met at higher values.
Another diagnostic criteria they endorse is waist circumference, which is measured at the level of the iliac crest. We'll tell you the cutoffs where someone might be considered high risk for overall mortality, heart disease, diabetes, hypertension, dyslipidemia, and non-alcoholic fatty liver disease.
So the North American measures are men, 102 centimeters or larger waist circumference, and in women, 88 centimeters or larger.
In Asian men, it's over 90 centimeters, and in Asian women, it's over 80 centimeters.
So don't memorize these extra ones, but it's good to know that different ethnic groups are going to have different distributions of what quote-unquote normal should be and the added risk that comes with that. Childhood obesity is not classified as BMI absolutes. Instead, they have percentile cutoffs appropriately based on the WHO growth charts. These are standards that identify how the child should grow when they're in optimal conditions. For these kiddos, overweight is usually above the 85th percentile.
Obesity is over the 97th percentile.
And severe, 99th 99.9%.
So for annual visits, it's suggested to collect a height, a weight, calculate BMI, and for those adults at BMI 25 to 35 to measure a waist circumference to better risk stratify. But remember that neither BMI or waist circumference alone adequately determine a person's risk. They are proxies. Staging with a tool like the Edmonton Obesity Staging System, EOSS, better determines risk. Take a second to image search the EOSS because there's an excellent graphic that explains this, which we will link to in the show notes.
The second part of the objective has a ton of nuance to it. It's also probably a great one for an oral exam scenario. Eleanor, tips and tricks for informing patients of their new diagnosis of obesity?
The thing is, Caleb, patients are not oblivious. Larger people...
I've met patients.
Yeah, did you know? They've lived with this for a long time, usually, and larger people face stigma regardless of if they fit any medical obesity criteria or not. According to the 2020 Obesity Clinical Practice Guidelines, that bias actually increases morbidity and mortality independent of weight or body mass index. So the more we judge, the more harm we do. It means that it needs to be dealt with tactfully and sensitively so that we are not part of the problem.
The new obesity guideline does encourage asking patients permission to talk about their weight, just like you would, I guess, with anything. If they're here to talk about something specific, then don't go talking about other things. Got to be ready for them to say, no, I don't want to talk about it, in which case just move on and address it at a future point. As Eleanor said, they're probably already aware, and if you've asked them if it's okay to talk about it, they're doubly aware. So move on. They have the right to discuss what they do and do not want to talk about.
Yeah, we need consent to have these conversations.
Objective 2. In all obese patients, assess for treatable comorbidities like hypertension, diabetes, coronary artery disease, sleep apnea, osteoarthritis, as these are more likely to be present.
This is in line with the Edmonton Obesity Staging System, where a concerted effort should be made to treat obesity along with these obesity-associated diseases, especially the more severe the disease becomes. As mentioned before, BMI and waist circumference alone aren't enough to assess risk level and to plan for treatment, but identifying comorbidities provides targets for treatment. We won't go over the treatment of these conditions today.
You can have an elevated BMI, but not have the disease state of obesity per the EOSS. These patients can be large and happy and healthy. The note here we have is Lizzo. She's a vegan. She probably has insane cardiovascular fitness, probably way better than I do because of all of her performances. And if we were just going strictly by BMI, we would probably consider her unhealthy, but based on lifestyle, there's a good chance she's got decent blood pressure, lipids, and A1C.
Yeah, I think the most important takeaway here is don't judge a book by its cover. And that's where the EOSS does it right. It tries to separate size from health in a way that says, yes, obesity can be a disease, but you can also have a big body and be perfectly healthy.
And there's tons of thin people that we've all met with high blood pressure, with dyslipidemia, with diabetes, and some large people who are perfectly healthy. So you need to be a good doctor and meet people where they're at and recognize the differences between correlation and causation. Come on, that's core stuff.
One thing I see on social media that concerns me personally is that people in larger bodies avoid doctors because in their experience, all physicians want to talk about is weight loss. And in addition, any symptoms these people have are attributed to their size without the consideration of other medical conditions.
It's the number one rule. Keep a wide differential. Check your biases. Don't inadvertently miss a serious problem. And in this case, probably anchoring bias is the big one that we really screw up. We assume everything is associated with that one disease state, if that disease state is in fact present. And we forget that they're a human with a whole bunch of body parts that can go wrong however they want.
Exactly. Important to remember those things.
Objective 3. In patients diagnosed with obesity who have confirmed normal thyroid function, don't repeat TSH. There's an association between obesity and hypothyroidism, but not a causal link. That has not been established. Overt hypothyroidism is associated with modest weight gain, but a similar link for subclinical hypothyroid is not so clear. There's no indication to treat obese folks with levothyroxine except in the context of actual hypothyroidism. In these cases, you may see modest weight loss while they are being appropriately treated.
Within their family medicine section, Choosing Wisely Canada recommends not ordering thyroid function tests in asymptomatic patients. Like other medicine, it's not prudent to chase possible causes of a condition like low thyroid hormone, especially if there's not really any, symptoms that go along with it.
Easy peasy. Choosing wisely. Objective 4. In obese patients, inquire about the effect of obesity on the patient's personal and social life to better understand its impact on your patient. The all-important history-taking technique that we've all learned and mentioned 48 times if you've been listening to these episodes in order is crucial in OSCEs. It's crucial in your oral exams, but it's also very crucial in real life. And if you're a med student listening to this, please know that we harp on this for a reason, because honestly, it matters, and you're going to get tons of rapport building with your patient, and you're going to get actual, real, legitimate information because you've connected with them. So this can be a huge help in guiding the conversation towards what's actually important to your patient, and that's the only thing that matters.
Yeah, specifically, you can ask people if they're concerned about managing any self-care activities.
And you can assess fall risk, because that can impact their ability and interest in physical activity in the first place.
I do think that family medicine, through the FIFE and other things, has really helped to be able to read people and kind of have those like human interactions even within a 15-20 minute appointment, which is kind of wild.
Objective 5. In a patient diagnosed with obesity, establish the patient's readiness to make changes necessary to lose weight, because the advice will differ, and reassess this readiness periodically.
Wow, what an objective. Caleb, is that really our goal? Purely weight loss?
Yeah, I've started actually removing arms if they want to lose some weight.
Just a casual amputation.
That'll improve their BMI.
100%.
Yeah. Won't that fix that measure? That super awesome BMI measure we've got? More seriously, why shouldn't that be our goal if we know that obesity is associated with so many different health conditions and all-cause mortality?
I think that's a bit of a flawed understanding. The more I read about this topic, the more I've come to realize that fat is not the primary problem. It's health behaviors in a person's environment that drive obesity as a disease state.
Go on.
We've already established that weight stigma impacts health negatively. Let's take the focus off size and rephrase this objective in a way where we can actually tackle it. Objective 5. In a patient diagnosed with obesity, establish the patient's readiness to make changes necessary to improve health and reassess readiness periodically.
Is that what I sound like?
That is a perfect imitation.
I thought so too. It was like listening to myself.
The people will support me.
I know they will. Okay, so this is more in line actually with the clinical practice guideline that says we should shift our focus of obesity management towards improving patient-centered health outcomes instead of just weight loss all on its own.
And truthfully, sometimes patients are hyper-focused on weight, so we don't need to dismiss it entirely, but rather understand that good health behaviors can be beneficial despite not leading to weight loss.
Totally. And so the classic for assessing if somebody is ready to change, the stages of change that we know and love and we'll review here are
pre-contemplation.
And then contemplation.
Then you have preparation.
And finally, time for action.
But don't forget maintenance, the tricky one, which is a perfect segue into the next objective. But just to kind of close the loop on this one of the phrases that I like to use to ask people about the things that they do for their health is, how do you move your body in ways that you enjoy? Because if you like it, you'll stick with it. Some people use their pets as an excuse to stay active. Others love to watch a favorite show exclusively at the gym or play rec sports. Whatever they like, encourage it, because habitual activity is great to avoid injury and promote cardiovascular health.
Yeah, I do a similar approach. I like when we're talking about that 30 minutes of elevated heart rate 5 times a week. I basically say your heart doesn't know or care why it's pumping. So if you're dancing around the room with your niece 30 minutes a night or rolling down a grass hill, honestly, it doesn't care. It doesn't matter as long as you're moving.
Yeah, that's a great way to say it too.
Objective 6. Advise the obese patient seeking treatment that effective management will require appropriate diet, adequate exercise, and support and facilitate the patient's access to these as needed and as possible.
Medical nutrition therapy and exercise are the main pillars of managing obesity, regardless of body size or composition. For exercise, it's recommended, as you just mentioned, to do about 30 to 60 minutes of moderate to vigorous exercise most days of the week. Who among us hits these goals? I wonder. But interestingly, a Cochrane review by Shaw et al., which looked at over 3,600 participants in over 40 studies, concluded that exercise alone resulted in small amounts of weight loss, just around 1 kilo. But the cool finding was that exercise is associated with improved cardiovascular risk factors, even if you lost no weight at all.
Diet-wise, personalize it to meet individual values, preferences, treatment goals in a way that's safe, effective, nutritionally adequate, culturally acceptable, and affordable for long-term adherence. If it's possible that they can get a registered dietitian, that would be amazing. Options for diets vary. There's caloric restricted, there's DASH, there's Mediterranean, and on and on and on, as well as specific recommendations for food groups. The Canada Food Guide was updated recently, and I find it super helpful to look at that plate. And it's not sexy. Like, we need a way of making just eating whole fruits and vegetables and whole grains sexy, but we need like a website and influences or something, I think.
The principles for these diets should be discussed with patients, and I think it's actually really important to move the focus on to what the patient is willing to adopt as a long-term behavioral change that is sustainable, rather than focusing on just eating less or choosing good foods, because that is the mindset which can lead to disordered eating. And that's why most diets fail. And was one of the people who did the podcast on eating disorders. And those have the highest mortality of any diagnosis in the DSM. So it's a serious issue if you're pushing someone towards that.
Totally. The guidelines that we referenced do provide some helpful key messages for folks living with obesity. And these can be adopted as phrases for counseling. Some of those are:
there's no one-size-fits-all healthy eating pattern. Choose an eating pattern that supports your best health and can be maintained over time rather than a short-term diet.
So keto, right?
For sure. Not expensive at all.
Another one is: how you eat is as important as what and how much you eat. Practice eating mindfully and promote a healthy relationship with food.
End quote. Caleb, do you know about the Tools for Practice put together by PEER, the Edmonton-based primary care research group?
I should, but I don't.
Oh, well, according to the script, you do.
I do. Go on, tell us about it.
Yeah.
Not for my benefit, for the listeners, of course.
Of course. They're about 1 to 2 page articles developed free of industry bias. They're based on best available evidence like trials, reviews, meta-analyses, and they provide clinicians a focused answer to a clinical question. So basically, they're very helpful. Some of the questions from recent articles are particularly relevant to this discussion. So there's one from 2015 that posed the question: is any diet better for weight loss or preventing negative health outcomes? And their conclusion was that weight loss for all diets is very similar if you're looking at a 2-year span. Only the Mediterranean diet demonstrated positive results on hard outcomes like mortality, despite not causing any difference in weight or surrogate markers like lipid profiles.
What?
So I know.
So it improved mortality, but it did not necessarily change their weight.
It goes against a lot of the assumptions that we have. They also noted that in cohort studies, when obese people intentionally lose weight, mortality results actually vary, sometimes increasing, and often that's in older people. The evidence they reviewed suggests that physical activity has more impact on outcomes like mortality than weight loss alone.
I get the dad joke. Food for thought. Objective 7. As part of preventing childhood obesity, advise parents of healthy activity levels for their children.
The Canadian Pediatric Society has helpfully put out a physical activity guideline. Although it is about 10 years old, it provides guidance on the amount of activity that kids should have. So infants under 1 should have activity several times a day, apparently. This is mainly through floor-based play like tummy time, reaching, pushing, pulling, and crawling.
I was going to laugh initially because try and stop an under 1-year-old, but I think there's something to that, like the reaching, pushing, pulling. You can kind of encourage that and do it multiple times per day, so that's cool. Once they're 1 to 2 years old, aka toddlers, or 3 to 4 years old, aka preschoolers, they should get 180 minutes, that's 3 hours of physical activity per day of any intensity. So this could be structured or unstructured. Make sure it's got different environments to keep them stimulated, activities developing their movement skills, and then aim to progress to 60 minutes per day of energetic play by the time they hit 5. So play, games, transportation, recreation, physical education.
And then for children and youth, so age 5 to 11, 12 to 17, the recommendation is about an hour of moderate to vigorous physical activity a day. Luckily, schools often have a gym class, which would suffice for this, but it is good to have families involved. The other thing to know is that they should be doing exercises that strengthen muscles and bones at least 3 days per week.
The guideline also recommends minimizing the time spent sedentary and limiting the time spent on screens. Oh my gosh, Grandpa was right. In 2019, there was an updated guideline from the Canadian Pediatric Society on screen use that acknowledges the ubiquitous nature of digital media in recent years.
This guideline focuses on clinicians and families incorporating 4 principles, which are the 4 M's, if you're trying to memorize it: healthy management, meaningful screen use, positive modeling, and balanced/informed monitoring of screen time and behaviors. We won't get into this anymore here, but we think it's important to point out that this resource exists if patients are asking for specific.
And if you can not pick up your kid from school in a car, then do it. Walk home, ride home, these kinds of things. That's like a social-wide thing, though, that we have to work on. Yeah,
this is kind of off script, but there's so much of health that is built society, built infrastructure, and then don't even get me started on the amount of money you make and how that influences your health. We do our best with what we have, which is influencing people's health behaviors, but there's so much more that's outside of our scope that has huge, huge impacts on our patients.
Objective 8. In managing childhood obesity, challenge parents to make appropriate family-wide changes in diet and exercise and to help avoid counterproductive interventions. The CPS has a position statement from 2012. Also, it seems like they're ready for a refresh on that, on the psychosocial aspects of child and adolescent obesity that provides recommendations for how to engage parents in adopting family-wide behavioral changes. They suggest motivational interviewing to encourage parents to consider the change and encourage them to become more sensitive and non-judgmental. You remember motivational interviewing. They recommend assessing whether changing family behavior is a priority and assess how confident the parent or the parents are about achieving these required changes.
Some examples could include parental eating choices, like limiting high-fat and sugar foods, focusing on healthy snacks, and avoiding casual snacking. Avoiding using food as reward or bribe, that is huge. And having meals together as a family. The other one is avoiding missing breakfast, exercising together as a family, and having healthy and consistent routines. The other thing is having supervision at home.
It's important you encourage the parents to be sensitive and non-judgmental. That you don't want them to be stigmatizing their own children. This could be an opportunity to talk about how other negative social interactions with others like bullying can cause emotional eating behaviors. Please look back on the eating behavior episode.
That is all for the objective of obesity from the CCFP, a rich topic. And there's so much more to talk about. I really wish we could cover more, but Caleb is strictly cutting us off under the 30-minute mark. Good, strong leader here. The best way to learn more is to check out the links in our show notes. So consider reading some of the Tools for Practice articles to help cut through the myths around size and health.
No, you guys might not know, but that was tongue-in-cheek. I've been all over the place, and she's desperately trying to keep me on script throughout this entire episode.
If you hear the whip cracking,
it's coming from the other direction. Yeah. The reference here is made to White Coat Black Art podcast episode on the CBC, where Dr. Brian Goldman interviews bariatric surgeon Dr. Arya Sharma, one of the creators of the Edmonton obesity staging system. I'm going to have a listen to that myself too.
Yeah, it's excellent. Or, if you want to be on the cutting edge of this stuff, look up Health at Every Size. It's a movement. Explore the concepts of intuitive eating. Read the UBC article, This Changed My Practice, by Dr. Katrina Wind, explaining why she no longer prescribes weight loss, calculates BMI, or uses the term obesity.
It's on my list as well. Thanks for joining us again on The Generalist. You are a wonder. We're so thankful for you. If anyone else wants to jump on board and complete some of the episodes that aren't done, or if you're interested in some of the other topics that are coming up, or anything else that generalists do in this wonderful profession, which is everything, give us a shout and your ideas. We love your passion.
Thanks so much. I highly endorse getting involved. It's really fun.
Nice. Okay, bye everyone.
Bye.